Good afternoon, everybody. Welcome to the third in our series regarding healthcare financing. We've heard from two individuals already talking more on the wonky side, if you will, of healthcare financing. Today, we're going to have a discussion in regards to really the nuts and bolts of um, getting the best insurance you can through the UC system and all the implications of the various insurance policies. And we're really fortunate to have somebody who knows more about this than just about anybody I know, and that's Ken Polse. Ken's a professor of the graduate school and the Edward A. Dickinson Emeritus Professor, Herbert Wertheim School of Optometry and Vision Science here at UC Berkeley. Ken's, as I said, just a wealth of information, practical information in regards to our health insurance, and I'm sure you're going to find this very valuable. I certainly appreciate, Ken, you being here today. So thank you.
Thank you, John. It's a pleasure to be here.
Yeah,
The more
sure.
I look into this,
Yeah.
the more I look into the insurance, I find it gets more and more complicated. As you heard from Steve Shortell, those of you that attended last week, it's no surprise that the U.S. among developed nations always seems to take the last place as the uh, least affordable and least effective healthcare program among developed countries. Part of it is because of the complications of accessibility and cost that really affect the quality of care. Let me just give you a thumbnail sketch of where I'd like to go today, and I want to leave time for questions. And I'm really fortunate that Gabe Schmidt, our Berkeley healthcare facilitator, is here, and he'll help me answer questions and also point out when I may make an error, which is easy to do in this complex world of health insurance in this country. But I'm going to make some general comments about retiree health insurance in general, and then I'm going to focus on the UC Medicare plans. We have plans that are for retirees that aren't on Medicare, but that would take another whole lecture. So we're going to concentrate on the UC Medicare plans. And then I want to spend just a little time on recall for those retirees who are planning or who are on recall and the new rules and how it might or may not affect your health retirement plan. And then finally, given time, I'd like to just spend a moment on the Reconciliation Act of 2025, the big beautiful bill, and its impact on our health insurance and what it might mean going forward. Well, I think I don't have to tell this audience anything you don't know, that how complicated health insurance is in this country. If you talk to friends or colleagues abroad in other developed countries, they have no idea what we're talking about when we talk about going bankrupt from health costs, prior authorization, co-pays, co-insurance, so on. It's a very complex system, and it's what also makes trying to figure out what policy, what plan may work best for us is complex. You just can't go on the price of the premium. There's so much more to it. So let's just talk about some general information first. When I think about medical insurance, first I think about the coverage and the cost of the plans. What's covered in the plan? What are its costs? What are the deductibles, the copays, the coinsurance? What's the out-of-pocket maximum? Is it capped, or will I have to continue to pay? Who's in the provider network? Are there providers that are out of network that I won't be able to reach or that won't accept the insurance company, or simply I'll have to pay a lot more in my copays? So I think about those things. The next thing is the access. Will the plan give me access to the providers I need to see? And in that access, there's prior approval. Will many of the conditions or treatments that the provider wants to perform require prior approval before they can go forward? Am I likely to have denial as not medically necessary? Are there a lot of services under a particular plan that I may need that may not be covered in this plan? And What about if I'm unhappy? What are my options to change to another Medicare plan? So I want to think in general about those things. These aren't as complicated for those of us that are in the UC group plans, but for our UC retirees who are living out of state, these are very important considerations. And finally, drug costs. Um, is the drug plan Are the drugs on the drug plan formulary the drugs that I need, or are they non-formulary, which may not be approved and that I will have to pay out of pocket? What are the copays, deductibles? What's the out-of-pocket maximum? And the the drug plan includes what we call Part D, which I'll get to later, but there's also drugs covered under Medicare Part B, which is different. And I'll have a chance to mention that and some reasons to consider drugs covered by Medicare Part B. So Medicare's broken down into four parts, A, B, C, and D. Originally, back in 1965, it was the idea was started by John Kennedy, of course, and signed into law by Lyndon Johnson in 1965. And there were only parts A and B. It's sometimes referred to as original or traditional Medicare. Its operation is set up by the Center for Medicare and Medicaid Services, often referred to as CMS. And it's a federal insurance plan. It's run by the government. CMS sets the reimbursement rates. It sets the procedures and treatments that are approved. Interestingly, that up to date prior authorization for procedures are not usually required. If your provider asks for or wants to do an approved Medicare procedure, the provider does not need to seek prior approval. Although there is, and I'll mention again just a letter, there is an experimental plan in 6 states using artificial intelligence looking at PA. It'll be several years before we know the results of that, but Medicare is considering some type of prior approval. Whether it will happen or not is to be continued. Um, Medicare Part A covers your hospital insurance, inpatient, some short-term skilled nursing facilities, hospice care, and some home care services. Medicare Part B, which is what most Medicare patients use a lot of, covers office visits and preventative care, lab testing, ambulance services, ER, urgent care, durable equipment, outpatient care, outpatient surgery, imaging, physical therapy, and so on. And it also includes some drugs. And if the drug is administered in a hospital setting or in a provider setting, it may be covered under Part B. And for very expensive and drugs that require lots of prior authorization going through the drug plan, Part B is much easier for those kinds of drugs, and it's the same cost. And I'll come back to that again a little bit later. A lot of people don't know about requesting from your provider to go through Part B. Um, Actually, Medicare Advantage, the basics of Medicare Advantage began in the 70s, and it went through a number of iterations or HMOs, but it actually became law in 1997. And it's called Medicare Part C. And Medicare Part C really includes A and B and a drug plan. So it includes hospital coverage, outpatient care, a prescription drug plan. And unlike original or traditional Medicare, Medicare Advantage plans are offered by private, nonprofit, or profit insurance companies. And we have one of each in the UC group plans. These insurance companies get paid not on a per visit or per treatment basis, but on a per capita. Each year, the insurance company puts in a number of diagnostic codes depending on your physical condition, diabetes, high blood pressure, and so on. And based on the type and number of health conditions you have, they get a one-time payment, a yearly payment, that is to cover all of your costs for that year. And they're very cognizant of that. So it's to their benefit for you to have as many diagnostic codes as possible. If we have time, we'll talk about the implications of that later on. What's also important to recognize about these private insurance plans is that they determine, not the Office of Medicare and Medicaid, not CMS, but the insurance company determines who's in the provider network, what services are covered. Usually, the Medicare Advantage plans include all Medicare practitioners, but not necessarily I shouldn't say all Medicare. They may have a network. Within that network are Medicare practitioners, but it may not include all Medicare practitioners as we'll find out in a moment. Um, Also, these private Medicare Advantage plans can decline service. The justification typically is the phrase not medically necessary. Um, and that's true even if Medicare lists it as a covered service. What would be required then is for your provider to write a letter of appeal to the insurance company. This can, depending on the insurance company, depending on the plan, a decision can be made rapidly. In some cases, it's not made rapidly at all, but they can decline a service. Some of the MA plans, the HMO plans, require a gatekeeper. That is, you have a PCP and they orchestrate who you can go to and referrals and so forth. And some are a PPO plan. In the UC group plans, we have one of each, and I'll mention that a little later on. Uh, Part D is the prescription drug plan, and original Medicare. If you are an individual and have original Medicare, if you have a Medigap, and I'll mention that, a supplemental plan, they may have a drug plan rolled into it. That's what we do with our group plan at UC, but often not, and that you will have to take a private drug plan to get drug coverage. In the Medicare Advantage plan, as I mentioned, they include a drug plan, almost all Medicare Advantage plans. Some of you who are in Medicare Advantage plans, and some of you who are in original Medicare plans, which have a drug plan, you may have noticed that your Social Security letter that you get every year mentions that you are still paying a Part D premium, and that has to do with your income-related monthly adjusted amount income. And I'll explain what that means a little later on. So even though the Advantage plan offers you a drug plan, or the Medicare supplemental plan offers you a drug plan, you still may be paying a premium to the government, which is deducted from your Social Security. Okay, let's talk about healthcare insurance for UC retirees living in California. For when all the family is in Medicare, we have 5 plans available. When one or more members is not in Medicare, UC offers 3 plans. And when all members are under age 65, not eligible for Medicare, there's 4 plans available. I'm going to be concentrating on just the first one, the Medicare plans. Now, but just to mention about those of you who are either already out of state or you're contemplating retiring out of state or you're retired in state, but you're thinking about moving out of state. It's important to know that if you and your family, your spouse, for example, are both in Medicare, you will leave the UC group plans and you'll be in the individual insurance marketplace. UC has set up a insurance counselor. It's called Via Benefits, and you will have an opportunity to talk and discuss different options and plans. Um, you can also purchase a Medicare plan, original Medicare, or a Medicare Advantage plan. If you purchase the original Medicare plan, Via Benefits will discuss with you the supplemental plan to Part B because Medicare Part B only pays 80% of the covered services. The other 20%, which can be substantial, most of that, and sometimes all of that, can be covered by a supplemental plan to Medicare, which you would pay for out of pocket. And but UC gives each eligible member $4,000 a year to purchase not only a supplemental plan, but pay for other medically related services. Um, when one or more family is not eligible for Medicare, you stay with the UC retirement plans till all members are Medicare eligible. So you continue with whatever plan is appropriate depending on where you're living. Okay, what's included in the UC group plans? Not the out of state, but the UC group plans. Let me just preface my what I'm going to talk about saying that having looked at a lot of plans, a lot of individual plans, we at UC are very fortunate. We really have, no matter what troubles you've had, what experience you've had, compared to many, many people that aren't in our plan, we have a really good plan. And I'm including that in the drug plans, which I know some of you have had trouble with over the years. All in all, we have good plans and we're hoping that we can keep it that way. But what's included? Hospital care, outpatient services, and it includes covering most, if not all, of the 20% cost not covered by Medicare B. It depends on the plan you choose. But most of the 20% is covered with sometimes a small co-insurance and sometimes not. What's also of importance, Medicare Part A and B have deductibles. The Part A is around $1,400 a year and the Part B is about 260. We don't pay those in UC. Those are our insurance covers those. Um, we have an out-of-pocket maximum. It varies between about 1,000 and 1,500 depending on what plan you're in. We have no lifetime cap, and that's true of private insurance also. At one time, there was a lifetime cap, and it was given the rising cost of healthcare, it was very problematic for some people that got sick, but very sick. But it's not a problem now. Coverage for travel outside the United States. All of our plans cover some form of coverage out of the United States, but I want to point out that coverage does not include emergency medical evacuation. That can be a very, very expensive procedure if you had to be evacuated back to the United States. So I always tell people, consider a separate travel insurance plan if you're going to be traveling that covers emergency medical evacuation. And all the UC plans include a prescription drug plan, which I said are quite good. Okay, what types of plans do we have? Well, I said we had 5 plans. 3 are original Medicare plans. That is, they cover A and B and also include a supplemental plan to B. And we have 2 Medicare Advantage plans. And also, and I'll mention this again later because it's important for those of you that are out of state, that during the open enrollment period, we can switch plans. If we don't like the plan we're in, we can take the other plan. There's no medical underwriting, no concerns there. And that's a tremendous option that a lot of people don't know about, but that's not necessarily available in the individual market, as we'll talk about later. So what are the costs? And I always, when I'm talking to colleagues and friends about this, I say, people always think about the costs as what's the premium? What are they going to deduct for my annuity check? And I guess that's fair, but there's so much more to costs that you can't just look at what they're deducting from your annuity check. But I want to tell you first how UC determines how much they're going to deduct from your annuity check, depending on what plan. UC negotiated several years ago a 70-30 split that UC would contribute 70% of the cost and the retiree would pay 30% of the cost. but it's not quite that simple. It's not 70% of what your premium really cost. It has to do with a average cost. So what UC does is they calculate the premium using the UC Medic, all the five UC Medicare plans, and they determine what the average of that is. That's their 70% contribution. And that average is contributed towards the actual cost of your plan. So in summary, they calculated 70% is contributed towards your plan cost. If your plan cost is relatively low, the amount they deduct from your annuity check is going to be small. If your plan cost is relatively high, that 70% is not going to go as far, and your deduction from your annuity check will be higher. Okay, what about additional costs that are not covered by UC? Well, I think all you know that you get a deduction from Medicare Part B, and the amount that they deduct is based on your what's called the income related monthly adjusted income, or IRMA, which basically is your adjusted gross income plus your tax-free income. And there's different brackets, and that's for both you and anybody else on your plan that's in Medicare. So if you're both getting Social Security checks, it'd be deducted from both you. If one of you isn't getting Social Security checks, you would have to make a direct payment to the Social Security office. But typically, it's deducted monthly, and once a year, the Social Security office looks at 2 years back of your tax returns to determine your IRMA, and that's how they decide how much they're going to deduct from your Social Security check. The same is true for Medicare Part D. Even if you have a drug plan, which we do in the UC plans, they still look at your IRMA, and they can, depending on what it is, depending on your bracket, will deduct a Part D premium from your Social Security check. Now, except for the letter you get from the Social Security office, or if you go on your website of Social Security, it's all lumped into one. You just get a Social Security deposit in your account, but those deductions have occurred. They have taken them out. So if you're ever interested in that, rather read the letter that you get. Usually comes late fall, usually around November, maybe early December, depending. And you can appeal it if you think they've made a mistake. Okay, original Medicare, three plans. Um, there's the UCPPO plan. There's the UCI high option to Medicare, and there is a UCPPO plan without drug coverage. Some people can have, if they have what's called credible drug coverage, their spouse or something has a plan, they don't have to have the drug plan, and the premium is substantially less. Um, I think the majority of people don't have that plan, but it is an option if you qualify. Okay, what's the some details of the original Medicare plans? First of all, and this is true of all the UC Medicare plans, you must be enrolled in Medicare Part A and B. And UC will remind you of that quite frequently if you fail to enroll in that. Um, the coverage in the Medicare plans, as I mentioned, is covered by the CMS. Access. Who can you see? You can see any Medicare provider in the United States. You want a second opinion at the Mayo Clinic, you want a second opinion at the Anderson uh, uh, Clinic in Texas, so on and so forth. You are eligible to have that done. Um, the supplemental plan covers most or all of the 20% not covered by Medicare Part B. The UC high option to Medicare, which is the most expensive premium, there is no out of pocket. It covers everything. The UC PPO covers, um, to, to summarize it, it covers about 4%, actually about 4% of the Medicare approved procedure. So it's a very small copay, um, even when you have a rather large Medicare bill. Um, Generally, in these plans, prior approval is not required. And in fact, if you have a procedure and Medicare determines that it wasn't covered, It's actually the provider that's responsible, not the patient. This is pretty unusual, but it can happen. Um, Under the Medicare plan, you can get second opinions. In some cases, you can get third opinions, and you don't need prior approval to do that. So if you want surgery is recommended and you want to talk to more than one surgeon, that's covered. Outside the US, 80% of the covered is covered, and 20% is your responsibility. Um, it turns out that most of the coverage in other parts of the world is very inexpensive, so that 20% doesn't amount to much. And if you have travel insurance, part of that will be picked up by the travel insurance. So it's not a very big amount that you have to worry about. Just to let you know that the supplemental plan is actually self-funded by UC and it's administered by Anthem Blue Cross. And every year there's a lot of confusion. People read that Anthem is no longer contracting with Stanford or they're no longer contracting with UCSF and so on. And people say, oh, they're on the one of the Medicare plans and they say, oh, but my providers are what's going to happen. It doesn't make any difference at all. You are covered. This has to do with people who don't have Medicare. If you have Medicare and a supplemental plan, which we have in the group plans, you can continue to go to any provider, even though that provider may not be covered by Blue Cross or Blue Shield or Anthem. It doesn't matter. You're covered. Okay. What about the Medicare Advantage plans? Well, we have two. And we have the Kaiser Senior Advantage, which is administered by Kaiser Permanente, and it's an HMO plan, which I'll get into in a moment. And we have UC Medicare Choice, which is administered by United Healthcare, which is one of the largest health insurance companies in the country. It is, I shouldn't say one of, it is the largest healthcare company in the country. So these plans differ considerably, and I think it's important that UC gives the retiree a choice between these two plans because they're quite different. And depending on your needs, one may suit you much better than the other if you're interested in a Medicare Advantage plan. So we're going to talk a little bit about these plans. Um, the Kaiser is an HMO plan. The services and the referrals are orchestrated through a primary care practitioner, which you need to have at Kaiser. Um, Almost always, you have to use Kaiser providers. There are some exceptions, but in general, you use Kaiser providers. The UC Medicare Choice is a PPO plan. And that means for our plan that we have at UC, that you can refer yourself to any provider that accepts Medicare. It does not have to be in the United Healthcare network. There are MA plans that United Healthcare runs in other parts of the country where you must go to their network, physicians or non-physicians, but they're providers. This is not true of our plan. Prior authorization, though, can be required. In the rules that regulate, if you read the explanation of benefits of the UC Medicare Choice, they reserve the right to ask for prior approval for just about anything that you would have done. Now, it turns out so far they have not enforced that option. They could at any time because it's in their explanation of benefits. The other thing they could do, but they have not done, is they could change the referral network. But right now, any Medicare, any provider that provides Medicare, you can go to. Okay, so in general, the MA plan, and this is the Kaiser plan. You can't go to an out-of-network pharmacy. You can't go to Safeway or to Walmart. You use the Kaiser Permanente pharmacy. It has lower monthly premiums compared to the other MA plan, UC Medicare Choice. You will need a primary care provider, and referrals are through your primary care provider. As in all UC plans again, you must enroll in A and B. You will need a PCP who will organize your care. You must use Kaiser providers. Occasionally, you can get an out-of-network consult. It would be most likely through your PCP. It can be done. It may take a little work, but it can be done. Um, the medical services that you will receive is determined by Kaiser, not by the Office of Medicare and Medicaid. Um, but what's covered, of course, is outpatient, inpatient, mental health, prescription drugs. It's just everything that you would want is technically covered. But again, what you get will be determined largely by both your PCP and anyone your PCP consults with. It's not determined by the Office of Medicare and Medicaid. And it does include a prescription drug plan. The UC Medicare choice is a little bit different. And as I mentioned, it's administered by United Healthcare. Again, the services that are covered are determined by United Healthcare, but basically, in their explanation of benefits, just about every Medicare procedure, if not every Medicare procedure approved by CMS, is listed as a covered procedure. But because it's a covered procedure, it doesn't mean that United Healthcare may not ask for prior approval. They certainly can. So far, that record is not, they haven't done that with the UC plan, but they again, and I want to mention that when you're thinking about it, they reserve the right to do that. Um, their monthly premiums are high, at least for 2026, are higher than Kaiser. The premium for Kaiser is zero, and they're also higher than the UCPPO. They're not as high as the UC high option plan, but for the UCPPO, they're a little bit higher than than the UCPPO. A PCP referral is not required for specialist care. That is, you can refer yourself, assuming that the provider will accept you without a referral, to a cardiologist, an orthopedist, etc. And it also includes a very good prescription drug plan. So, which plan works? Which one is best? So, it's so hard to make that decision. It so much depends on your medical conditions, um, the network that you want to have, where you want to go, and so on. But let me just tell you the good news. The good news is that if you have the UC group plan, you're not living out of state. Um, if you choose a plan and you're unhappy with it, during open enrollment, you can switch plans. There's no restriction, and that's an enormous benefit. Um, it's not true for our out-of-state Medicare retirees. If they have a Medicare Advantage plan that they've elected and they're unhappy with it and they want to go back to traditional Medicare, while they can switch to Medicare A and B, they will have usually tremendous difficulty getting a supplemental plan because the supplemental plan will now be subject to medical underwriting, i.e. pre-existing conditions. And therefore, the supplemental plan, if they can get it, might exclude a number of conditions that they have or just simply be denied. So for most people, if they don't have a supplemental plan to Part B, it can be in a very, very expensive health insurance plan, almost out of reach for most Americans, if you get sick. So people out of state that are considering a Medicare Advantage plan, while they can switch Medicare Advantage plans, there's only certain ways, certain things that allow them to go from a Medicare Advantage plan to original Medicare and get a supplemental plan. For example, if suddenly the private insurance company is not offering care in your area, they would have an option to go back to original Medicare. But most often they won't have that option. So it's a very important consideration when you're signing up. So what are the advantages of original Medicare? You've got this enormous network of providers that you can call on if you need, with additional consultations without needing prior approval. There's no network issues as long as you go to a Medicare provider, and you don't have to worry whether the area you're going to accepts Blue Cross or Blue Shield or Humana or whatever. It makes no difference. As long as they accept Medicare, you're fine. Um, the Medigap insurance, as I say, is included in the PPO, and therefore it really limits your out-of-pocket expenses. For the PPO plan, it's a maximum in the for A and B of $1,500 per calendar year. Um, and and in the UC high option, which as I say, it's an expensive premium, but there are no out-of-pocket expenses. What are the limitations? Well, it's definitely more expensive than the Kaiser plan. Um, and also, and this isn't trivial, the retirees have to select their providers. It's not like at Kaiser where they have a group of providers and they're there and ready to go to. You'll need to find your providers, or if you have a primary care provider, they'll help you find providers. But there's a certain amount of proactive and sometimes, as we're finding out, as providers get older, they retire, and patients are, well, who do I go to next? Now, fortunately, a lot of the group practices have people that, take over the patient load, but it is an extra step that one has to be aware of. What about Medicare Advantage? Well, it's all inclusive. Um, You don't worry about drug plans and so forth. Sometimes extra perks are offered, like vision care, dental care, gym memberships, etc., are offered. Um, I don't know currently what the UC Medicare Choice offers as extras, but I think they do have something with vision. I don't think it dental, um, but uh, and I don't know about gym memberships. Um, but the nice part about the UC Medicare Choice is you can see Medicare providers, and they don't have to be in the United Healthcare Provider Network. The limitation, it's owned by private insurance, for profit or not profit, but it is private. And they make the rules, not the Office of Medicare and Medicaid. And therefore, they can exercise prior approval. Denials as medically not necessary are possible, and it's anyone's guess when that happens, but in some cases it happens too often where it shouldn't. In some cases, it doesn't happen at all. Um, and although currently our plan, the UC Medicare Choice, has not limited the network of providers, they have that option. So those would be the limitations. Um, so it's very important during the open enrollment process to carefully look at what's covered, what isn't, does it fit your needs before you choose. And this is true, of course, even more true for out of state because you don't have the option necessarily of switching plans. So when I think about going forward, um, each year, and it's probably the crystal ball is the most difficult in this part because our system is getting more and more expensive and there's so many forces acting that are beyond our control. So I think about generally maybe a 7 to 12%, and that may be conservative, out-of-pocket increase because I expect um, Medicare Part B, C, and D premiums, that is what's taken out of our Social Security, to increase each year because the costs of healthcare is going up. I think about that the Medigap insurance that UC provides or that's provided within the MA plans is going to get more expensive. And therefore the UC premiums will go up. Your drug costs may go up, and the insurance, the copays that we have to pay or the coinsurance may go up. So I'm thinking about my overall out-of-pocket expenses each year may increase 7 to 12%. Um, I think another thing that's important is to have someone or more than one people that you trust, family members, close friends, relatives, that can advocate for you. When you're sick, it's difficult sometimes for ourselves to advocate for ourselves. And we need someone that understands what's necessary to advocate so that you get the kind of care that you deserve. And it may be a family member and it may not be, but it's important. And with the system becoming so complex and so difficult to navigate. It's important for you to think about having someone. And also have plans where you can go in case you need urgent care or ER care. Of course, urgent care is much more efficient if you can get that, but you need to know where they're located, what their hours are. They're frequent. Some aren't open on the weekends, or they're not opened after 8 o'clock in the evening, and so on, or not opened on Sundays and so forth. Um, so going forward, um, have a list of available providers, your PCP and the specialists that other members, in case you're ill, and other members of your family or friends or wherever you trust or who's advocating for you knows who these people are. If also consider at least looking into a healthcare manager to assist you with a home care, institutional care advice. There are home care managers that actually will come to the hospital and advocate for you. And there's a list of them. And depending on your thoughts, you might want to think about that. Um, Make your home elder safe. If you're not stable, don't be shy. Get a pair of walking poles and walk with them when you're outside or even inside. Um, and UC offers a course in fall prevention and or take a class in fall prevention. So, in summary, before we get on to the other part of our agenda, which I have a few minutes for before our Q&A, do your homework. Available plans. What's the benefit difference? Is this going to fit my needs as best as I can hope for? It's more than the premium. And I say that again, it's more than the premium. I know the first thing everyone does when they get the open enrollment book is they look at the premium. What's going to be deducted from my annuity check? I understand that. I do the same thing, but it's a lot more than that as you find out. And the more you have to seek medical care, the more you understand it's more than the premium. Who are the available providers? If I'm in an HMO plan, how do I get my primary care provider? Can I switch my primary care provider? How difficult it will be if I'm in a original Medicare? We're having a lot of problems in this country with primary care. What are the options? Uh, and if you check the available network, what providers and hospitals are available within the MA plan? Okay, let me go on just a little bit with recall. I think I'll take maybe about 10 more minutes and then we'll go into questions and answers. Recall is important because a lot of you out there probably are already on recall, and those of you that are prospective retirees listening to this might be considering recall. Well, things have changed effective July 1 of last year. The rules surrounding recall have dramatically changed. Actually, UC was a bit behind. We were out of compliance with federal regulations for many years. But come July 1, we're in compliance. And it has some real potential issues for retirees who are either on now or are planning on going on recall. So let's first talk about new retirees, those of you that are considering retirement in the next few years, and you want to be recalled within 6 months. You have a grant or you have a teaching obligation. So within 6 months of separation, you're going to be recalled with salary. The first thing that happens is that you will go on mid-level faculty staff medical insurance. Now, that probably will be less if you were at the equivalent of an associate or full professor salary. The mid-level faculty staff insurance will probably cost less than you're paying now. But it won't be as inexpensive as retiree health. But on the other hand, you don't have to enroll in Medicare Part A and B, and you'll avoid the Part B premium. So it could be almost a wash, but you don't have a choice. You don't go on to retiree health benefits for the if you choose to go on recall within 6 months of separation. Now, it's important if you plan that you want to go on retiree, you want to go on Medicare, that you make sure that your recall appointment is less than 43.75%. That's the only way you can eventually become eligible for retiree health benefits. there's an audit period. Usually is about a 1 year, a little over. It's from about November through October. So if you went on recall in August, you wouldn't be able to go back to Medicare uh, till after October the following year. So it's over 12 months. So you would stay on these mid-level faculty. But if the audit shows that you are greater than 43.7%, you will not be able to go on retiree health benefits. You'll continue at the mid-level. And it's the 43.75% is determined at the system-wide level. They have a way of auditing the hours. It's primarily based on your percentage appointment, but there are other things that can add into the percentage. For example, um, if you're giving some lectures and you get honorary at another UC campus, or you do a special assignment during the summer, and they give you an extra appointment, and you don't realize that that's added on to your original appointment. So it's important to check with your HR person to make sure that you're under that 43.75%. If you're not going to be recalled till after 6 months, that is, you retire in July and you're not going to be recalled, say, to the following January to the spring semester, you will actually then go on at the time of retirement, you'll go on to retiree health plans. And as long as your recall appointment is under the 43.75 after 6 months, you'll continue on that. Now, what about current retirees on recall? And that would include those that waited the 6 months and now they're on a recall. Um, you're on the retiree health plans, but you're being audited. That was something that didn't happen before. And we had not a lot, but we had some retirees who got a letter in the mail telling them that they were being taken out of the retiree health benefits plan and being put back on the faculty, staff health benefits, and that caused a lot of turmoil. So you have to be very careful if you're on recall and you're on the retirement health plan that your percentage employment is less than 43 point, should say 0.75. If it's greater, you'll be taken out of the retiree health benefits and put back to the mid-level. And that has all kinds of issues with respect to providers. Some of the employee plans are not haven't got the same level of providers or the same group of providers as Medicare. Um, You've got the problem of if you don't want to keep paying your Medicare Part B, you have to discontinue for Medicare Part B. That isn't so easy. And then you have to re-sign up for Medicare Part B once you go on a retirement plan. That isn't so easy, given that the Social Security office has had enormous cutbacks in their staff. So it's not convenient to go back and forth for most retirees. Um, okay. So that brings me to the third part and just a few minutes to just tell you what the impact of going forward is going to be with what's happening at the federal level. Primarily the reconciliation of 2025. Um, there's been enormous changes to both Medicare and Obamacare, and those two are going to have impact on Medicare. Let me just briefly summarize it. In 2026, it's estimated that about 5 million Americans who were eligible for Medicaid will lose their insurance. We don't know exactly, but there's new work requirements, new eligibility requirements. So there could be, and to a certain extent, it could be up to the state, but it's pretty clear that a lot of people who depended on Medicaid are now going to be uninsured. Um, Again, we don't know, but from 2026 to 2036, healthcare planners estimate that another maybe 5 million. So we could have 10 million people that were, as of today, are on Medicaid, lose their Medicaid benefits. Could be more, could be less, depending on if there's a change in Congress and and whatnot. It's subject to a lot of political stuff, but at the current trajectory, it doesn't look very good. Um, we also have another group of people, and I think you're reading about it in the news and hearing it on the news, that with the Reconciliation Act and the Trump administration chose to discontinue the subsidies to the individual premiums that people were paying on the Affordable Health Card, on Obamacare. And these subsidies made the difference between people being able to afford to purchase insurance. Also, the insurance premiums went up substantially. So there's a lot of people that chose to be self-insured. They just aren't signing up for it. Some people signed up for it, and I understand just simply aren't paying the premium. So they'll be taken um, off the rolls. So it's estimated, again, over the next 10 years, that it will lose another 10 million people that have been insured under Obamacare in the individual marketplace. Again, it could be more, depending on the cost of the insurance premium. Doubtful if it will be less, because it's unlikely that the insurance premiums are going to go down unless the government changes certain things. So, what does that mean in general? What it means is that there's going to be fewer patients covered under Medicare. It means more uninsured people. It means ending tax subsidies for the ACA will also add a substantial amount of uninsured Americans. What happens to these uninsured Americans? What choice do they have when they get sick? The only choice they have is to go to the emergency room. That is the only provider that will see these people. So we expect to see, and I think we're already seeing, an increase in the utilization of the emergency room with patients without insurance for what doesn't necessarily need emergency room, but it's the only place that they can go. Well, the hospitals that staff the emergency rooms or run the emergency rooms have no choice but then to raise their cost to the insurance companies for what the insurance would reimburse them for paying patients. So it raises the premium for those of us. In other words, the people that are insured are going to pay for the uninsured. It's the only way it's going to work. So, but there's a second factor here also that's unfortunate. In addition to the insured having to pay for the people that have been unable to afford their own insurance, um, there's an explosion of people coming into the emergency room. That means reduced access. It's going to be longer waits, harder to be seen, and of course, higher premiums for the insured. So, what does that mean for Medicare? It almost certainly means we've been seeing it anyway, but we may see even a stepped increase that the Part B premium that comes out of your Social Security check is likely to increase. The insurance companies, the UC problems that are offering us the Medigap insurance, we're likely to see an increase in our premiums there. The Part D is going up. And for the MA programs, it's pretty sure that you're going to see increases in the Medicare premium, the Medicare Advantage plans. And another reason that the Medicare Advantage plans are likely to go up, that the government is exercising more oversight on some of the current MA practices. This isn't completely true of Kaiser, but to somewhat, it's definitely true of United Healthcare, that they've been putting in some diagnostic codes that they might not have been to get higher per capita reimbursement. They're looking at this, the government's looking at this very carefully and deciding what they're going to do. But chances are that the per capita reimbursement to the MA plans will not be as high as previous years. So the only way that the Advantage plans can continue to work, if they're in the same manner, is to either deny more services or raise premiums. There'll probably be a little bit of both. In original Medicare, right now, the major concern is what they're going to do with prior authorization to reduce costs. As I said, it's being explored in 6 states. Will it happen? I don't know. They've picked out a half a dozen or 10 conditions that they think are sort of questionable whether Medicare should be covering them anyway. And they'll look at the results of this a few years from now. There may be other restrictions to reduce cost, but they haven't come up with anything. And then the other concern is that there seems to be no concerted effort in the federal administration to address the serious issue of loss of primary care providers. Like, say, and it's partly due to the organizations that have the providers in them, the American Medical Association, the and so on and so forth. But we need more primary care. We need more nurse practitioners. We need more physician's assistants and so forth. And although there's a lot graduating, there's no near enough to meet the needs of the country. So we'll see if the administration is going to look at that or some other organization. A lot needs to be done in that field. Well, I finished up that hour, so I think, John, we have time for questions and answers if there are. I don't know if there are any. I, of course, can't see them, but thank you for your attention.
Thank you, Ken. Well, we have a ton of questions,
Yeah.
but fortunately, Alicia Rivera from Rask has made your life a lot easier.
Oh, thank
Because
you.
as you've been talking, she's been wearing out her hands on the typewriter on her computer, answering questions. So thank you so much, Alicia, for your efforts. Um, I'll try and find some that she didn't answer.
Okay.
Can you sign up for VIA if you live in California? Now, there are a lot of questions, so probably you need to keep your answers pithy.
I
I
can I
did.
can answer the VIA questions. Um, so if you are living outside of California and you are enrolled into VIA and you move back to California mid-year, you will need to wait until open enrollment to re-enroll back into the UC Medicare plan. So you will need to contact VIA Benefits and enroll into a plan in the California area through the end of the year. And then if you do make that change during open enrollment, you will be back into the UC plan effective January 1st the following year.
Yeah. And I would add to that, that's exactly right. And be sure that the plan, since you won't be able to be enrolled into the UC plan till January 1 of that year, following year, be sure that you, if you're going to be in California and it's difficult to travel to wherever you are out of state, make sure that there's providers in that plan that you would have to have till January 1.
There are many doctors and healthcare professionals who are no longer accepting Medicare. Any other solutions?
I don't know what the percentage is, John. The last time I got a figure, it was 95% plus of providers were accepting Medicare. If you choose to go to a non-Medicare provider, um, you'll have to pay for it. Medicare is not going to pay for it, nor will your supplemental plan. Now, I'm not sure, and maybe Gaber can answer that. I don't know whether you can make an appeal to our supplemental plan to get coverage, but I would say it would be highly unlikely. I don't think there's many choices, but perhaps Gaber or Lisa want to comment on that.
Gabe is actually not on. I don't know if, and I think Alicia may have had to jump off
Oh,
too.
okay. I don't think there's many choices. Fortunately, most providers and all the nice part is in our area, and this is true of other parts of California, UCSF, Stanford, Sutter are all Medicare providers, so that providers, individual providers that work with them also are Medicare providers. So we don't have a large amount of, and John Muir, we don't have a lot of providers that don't accept Medicare in our area. And I think this is true in the big metropolitan areas. There could be a problem in the Central Valley and some of the smaller rural areas where I think that may become more problematic.
Okay, here's another one. My understanding is that if I am in HealthNet Blue and Gold, then when I turn 65, I automatically have to do United Healthcare Medicare Advantage. So change to UC Care next year, and when I'm turned 65, I can now opt for the original Medicare and UC offered Medigap plan, question mark.
Yes, yeah, is if both you and your if your and your other if both of you in the household or everyone in the household is on Medicare, you can involve for the original Medicare. If one of your family is not eligible for Medicare, there's three plans that you can choose from. Uh, one of the person on Medicare will choose from one of the Medicare plans. It can be the MA plan, or it can be the original Medicare, and then that will depend on what non-Medicare plan you get. But as long as everyone in the household is on Medicare, during an open enrollment, you can select which, if you want to do the original Medicare, the UC PPO or the UC high option, you can, and then that will become effective January 1 of the following year.
Thank you. Any recommendations for professional advocates for people with no trusted friends or family to fill this role?
Yeah, there are some really good healthcare advocates. I shouldn't be mentioning names, over this, but I do think that the retirement office the Berkeley retirement office may have some names. But if not, if you want to email me, I can happy to give you a couple names of people that do healthcare advocacy. But there are a number of people that do this, and it's not just advocating if you're in the hospital, but they can make suggestions about if you want to age in your home. They can make suggestions if one of you may need assisted care for a temporary period, or you may need nursing care. It can be quite complete. But I'd rather not give any specific names, but I can't remember. I think the retirement center may have a list of names. Uh, Camille, do you know if they do? I don't know if Camille's still on.
I'm on. I'm kind of honestly not sure, but I'll go and look at our stuff.
Okay.
If we have something, I can send it out.
Sure. Okay, good.
I'm in Kaiser now and still working. When, if I retire in June, will my PCP and other doctors at Kaiser automatically switch to the MA plan, or do I need to enroll again?
Well, if you're eligible for the Medicare Senior Advantage, you'll sign up for that during open enrollment. Likely, you'll keep your same PCP. Everything the transition will be seamless. But you won't automatically go on Kaiser Senior Advantage until you enroll in that. And I think that will have to wait to open enrollment. Um, uh, but I'm not 100% certain of that. You're talking about retiring July 1. If you're eligible for Medicare July 1, I think you may go on the Kaiser Senior Advantage when you do the retirement, unless you are doing recall. As I mentioned before, if you're going to retire July 1 and you're going to be recalled within 6 months, then you'll just stay on your regular Kaiser plan. If you are not going to be um, recalled, then I think you will go on any one of the Medicare plans that you choose, including Kaiser.
Okay, here's a tough question for you, Ken. Any solutions for finding a primary care doctor that is not a concierge doctor in Marin County?
Yeah. How
Um,
many times have we heard that, John?
I
It's
know.
it's uh, it's so difficult. Um, uh, a lot of primary care physicians are retiring, as you know, and there's no replacements. Other primary care physicians are going into concierge care, which is very expensive. Um, some we've tossed this around in our group before. Some people are switching to it's not a very uh, perfect solution, but like to One Medical Care, which they have a lot of offices. I think now One Medical may be owned by Amazon. I can't keep up with this, but in those uh, situations, you do have a PCP. You don't always get to see the PCP if it's an emergency, but you do have a PCP, and they can refer you to other physicians. It's not the same close relationship that you probably have enjoyed for many, many years with your PCP. But some people that have tried it are quite happy with it. They have a number of offices everywhere in the country, and throughout California. Um, the other is to ask friends and family who their primary care and see if they're accepting new patients and try that. Um, the In this area, um, the John Muir UC facility on San Pablo near Ashby in Berkeley has a group of primary care. Some of them are still accepting new patients. You can go online with them. They have a nice video about each of them telling them who they are and what they do. And then you can make a visit appointment to talk to them to see if you want to go to them. And there are, I understand, still some openings there. And there is the Stanford facility in Emeryville has primary care. And I haven't checked. At one time, they were still accepting new patients. Um, I don't know over the mountain out in the John Muir area. Uh, I can't give you any advice there, but those are the things I can, except for One Medical, that I can give you for this. Having said all that, no answer is a very good answer.
No, frustrating.
Mm,
Is there
very.
coverage? Somebody asks, is there coverage for concierge doctors? Many doctors in my county are leaving practice. My doctor of 17 years is one. Um, I don't believe there is, but Ken, do you know?
No, there's no coverage. You pay the concierge out of pocket. What you can, depending on how your taxes are done, that would be the amount of medical expenses that you can deduct has a lot to do with your overall income and so on. But if your income is modest and your concierge and your other costs are high, part of that might be deductible. But that you'd have to talk to your accountant about. But other than that, the insurance isn't going to pay it, and it's expensive. I've heard anywhere from as low as 5,000 to as much as $15,000 for concierge per year.
Somebody asks, I would like to know the considerations, pluses or and minuses, of if you want to switch from UHC, United Healthcare Medicare Advantage plan to original Medicare with UC supplement at open enrollment. I heard there could be disadvantages, but haven't been able to find out what they are.
Yeah, I don't think that personally there's any disadvantages. In fact, if you look, you'll see that this year in 2026, the premium for the UC PPO is less than the premium for the United UC Medical Choice. Also, the in general, the co-visits, the co-pay, the co-insurance that you pay on UCPPO, it's roughly 4% of the approved medical cost. So you have to have a pretty large Medicare approved expense before you would exceed the $30 office visit fee that United Healthcare um, chooses. The main difference could be is in the drug plans. You would have to look at what drugs you're taking and see if they are in the formulary that Navitus, who is the prescription drug benefit manager, at least this year. I don't know what it'll be next year, but for this year, probably the same, as opposed to Optum, which is the pharmacy benefit manager for United Healthcare. I would look at the drugs carefully. Chances are that they probably won't be too different, but you can't be sure. But I don't, someone else might have a comment on that, but I don't think there's any disadvantages on that. As I say, United Healthcare has been in its very, very best behavior because they could evoke, if they wished, a number of barriers to care, like prior authorization, denying claims, suddenly changing their networks. They've chose to do none of that, which is great. So it makes it a good program in that sense. But they do, being private, they do have the results. I don't know what the Office of Medicare looks at Medicare Advantage plans. They have some limited control, but I don't think they can stop the prior authorization, the denial services of the networks. I think that's out of their control. So, in a long answer to a short question, I don't think there's any disadvantage, and see some advantages to the UC PPO. Just to give you an idea, this year, I think about 30% of the people that were on on the UC Medicare choice switched over to the original Medicare, the UC PPO.
My husband will turn 65 before me. Can he enroll through UC?
No, I'm not 100% sure, but I think the answer is no, because you are the primary. And so I think you have to be on Medicare. But that's a good question for Gabe. That's a good question, but he'll know the answer for sure.
Any advice on out-of-state Medigap plans?
Um, Let me go into that because it's very, very interesting, and we've got a few minutes. So, when Medicare was approved and they offered, and they had B, and the Medigap plans, what's offered in the Medigap plan is the services that are offered are controlled by the Office of Medicare and Medicaid. If Humana wants to sell you a Medigap policy, and Blue Cross wants to sell you one, and United Healthcare wants to sell you one, all they can sell you is the premium cost. What's offered is set in stone. Now, having said that, it becomes a little complicated because there are about 9 Medigap plans, A, B, C, D, E, and so on. Um, some are more expensive than others because of what is included. One of the more popular is F, and I think it's G or F, which covers not only just about everything that we have in our group plan, our supplemental plan, but it has no out-of-pocket expenses for copays. It's 100%. But in those plans, because they're not group plans, you will have to separately choose a drug plan. And that becomes a little tricky. And I'll mention something, but first let me answer that question. You can shop price. Once you decide, I would go to the Medicare.gov and look at what the different A, B, C, D plans are, because you can't, once you select, if you select D, it's not easy next year to switch to C. You can switch to a lesser plan. You can't switch to a more inclusive plan. So it's very, very careful that you choose the right plan. Once you've decided on the plan, you can shop price. You can call the Humana, the agent, you can call um, the what whatever they are, the other plans, and choose for price. And often if both you and your dependent or the other person living is on Medicare, they give you a price break. So that takes care of the Medigap. But what about the drug insurance? Remember I said for UC, our drug plan is part of it. So we don't have to worry about it. And we have, incidentally, very good drug plans. If you priced on the private market what our plan costs, your eyes would blink several times. It's really, really expensive. So you can find plans that are maybe only $25 and $35 a month, but the out-of-pocket expenses are enormous. And if you have an expensive drug, it's very, very expensive. Now, one thing that you have to be careful about or recognize when you are looking at drug plans, the Office of Medicare and Medicaid used to have what they called a donut hole, and you had to go through about $8,000 of out-of-pocket expenses before the drug plan kicked in. It's now been set, I think, this year for about $2,100. So once you spend $2,100 of out-of-pocket expenses in covered drugs, formulary drugs, the drug company has to pick up all the cost. So that's one way to say, well, okay, I'll take a less expensive plan and I can afford the first $2,100 of out of pocket. The second thing that you want to realize is that some of the medication drugs you're taking may be covered under Medicare Part B. And it's important with the provider to find out if it is, because if you can get it through Medicare Part B, um, chances are you won't need a very arduous prior authorization, which you could need through your pharmacy plan. And And also that what you pay out of pocket there will go towards your limit, not the 2,100, but towards your Medigap limit, which will probably be between 1,000 and 1,500. After that, you won't be paying anything for that. So, and I know I apologize. What I'm saying is confusing and probably it's just we've made these things so difficult, maybe on purpose, but that's what I can say about drug plans and purchasing if you go out of state. It's very important that the person in Via Benefits that you talk to is really knowledgeable. I've had reports back that some of the counselors are terrific and some aren't so good. So if you don't like who you're talking to, try to get another counselor.
Thank you, Ken. We have two more. I turned 65 on April 30th of 2027. I'm currently in the UC Blue and Gold HMO. Do I need to switch to a different plan during open enrollment in order to start the Medicare high option plan once I turn 65 in April?
She turned 65 April did she turn 65 this year, April or not?
No, I will turn 65 on April 30th of 2027.
No, it's at that point it's at that point that she will. I think you want to double check with HR with Gabe, but I'm pretty sure that you won't be able to go onto the Medicare plan January 1 because you haven't turned 65 and you're not in Medicare A and B. So I'm gathering that you won't be able to do that either till after your birthday or perhaps not till open enrollment in 2027. I don't know exactly the answer to that, but I'm pretty sure that you won't do it open enrollment in 2026. But I think that's worth shooting an email to Gabe or a phone call. It's a good question.
Thank you. The last one, by the way, several people have asked, who's Gabe? Gabe Schmidt.
Yeah, okay. Gabe Schmidt is our UC Berkeley healthcare facilitator. He is a terrific resource. You're having trouble getting a reimbursement, you're having trouble with a provider, you're having trouble with a hospital, there's something that you were billed for that you don't think you should be billed for, or you have questions like we've just talked about. When do I sign up for this? When do I sign up for that? He is the expert in this field, and he's overworked, but he will get back to you. And so we were supposed to have two healthcare facilitators, um, but for some reason we don't. So he handles the Berkeley campus, both retirees and employees. But he's a terrific resource. And I think if you go on UC Net and you go to medical benefits and you go to Berkeley campus, I can't remember, you will see at the bottom Gabe's name with his contact information.
I can post that in the chat. And also I'm
Thank you.
posting Alicia, who was on here today, she has weekly Medicare office hours.
Oh, great. I didn't know.
Yeah, so there's a link that I'm posting here. So people can go to those every Tuesday from 12 to 1 to ask her questions as well.
Great. Okay.
Thank
And
you, Camille.
very helpful.
There's one last question, Ken. If you select UC Medicare PPO without prescription drugs, do you have to buy drug D plan yourself?
You have to have what they call a credible drug coverage, which means that you have to have either, most likely, you don't have it as a UC, so your your other person in the family, say your spouse, has a credible drug plan which you're able to go under, and you have to show that. There's specific rules about that. But you can't just elect not to have drug coverage. You have to have in place another drug plan. The specific rules governing that are both on UCNet, and it's again something that probably Elisa or Gabe could answer, but it's not simply, oh, I just don't want to have the drug coverage. That's not an option.
Well, Ken, I think we've worn you out. Lots of questions. Everybody's clearly got a lot of questions because the system is so confusing.
Oh, yeah.
Thank you so much for taking your time and effort to do this.
Yeah, Yeah, I apologize for all the complications, and it just as in a closing, every time I go over this, I find changes and things that I didn't. The more you read it, you find a little clause. There's always an exception, and it's annoying, but it's the way our system is working right now. And I'd sure like to see. I think I speak for probably everyone in the room, a better system. Um, but I think for the foreseeable future, we're got what we've got. And I think, as I said in the beginning, I think we're very fortunate at UC to have what we have, even with all the problems many of us have had. Thanks, John. Thank you, everyone, for attending.
Thank you.
Thank you. Bye.